Dr. Anshu Rajneesh. He's a consultant and head of nuclear medicine and PET CT at Kokilaben Dhirubhai Ambani Hospital, Mumbai. He's going to talk on quality assurance in nuclear medicine. Thank you so much for this upcoming lecture, which is very dear to us because quality assurance is what not foreign to us. So thank you so much. Looking forward to hear the session from you. Thank you, ma'am. Thank you so much.
Quality assurance in nuclear medicine and make you aware of how we work and how we do quality assurance in nuclear medicine. First, the quality actually the science of process of improvement. So in this, we expect there should be some improvement. Whatever activity we are doing, the objective is that there will be some improvement in the service. The quality care is actually doing the right thing at the right time, in the right way, for the right patient, and have the best possible outcome. So it is not academics that we are doing a measurement of a quality indicator for the academic sake. No, there should be an outcome. Then this exercise is fruitful, otherwise there is no use. The quality care is not luxury, but rather a necessity in current national health environment, affecting all the constituents of healthcare, including providers, regulators, payers, and patients. You can see this cartoon. The healthcare, the responsibility of providing quality care lies with the healthcare provider. But all these people who are expecting a quality care from the healthcare provider, one, referring physician, he wants his clinical question should be answered. If that clinical question is not answered in the report, it is a quality report. Patients, because they are paying, they think they are not beggars if they are paying for the service and they expect a quality service in this regard. The payers, insurance, they want justification of the indication of that scan. If the scan is indicated and then it is done in optimal manner, then they only pay for that scan. So even they feel they are the quality should be maintained. The regulators, watchdogs, they have an eye over the procedure, whether we are doing the right way or not, especially in the nuclear medicine department, because Atomic Energy Regulatory Board is seeing, because we are dealing with the unsealed sources. Unsealed sources we are injecting into the patient. So an unsealed radioactive material is moving in the department in various component or compartment of the department and is being injected into the patient. So this is very important that there is no spillage of radioactivity within the premises of the department. So regulators see to it that we follow the radiation safety protocol and the trained people work in the department. And public, of course, media and public, they're glaring on us. If we do one mistake, it becomes exaggerated in the media. So all people expect quality from the healthcare provider, and nuclear medicine people are also healthcare providers. In nuclear medicine, as far as the quality assurance is concerned, every activity in nuclear medicine department come under quality assurance. You cannot ignore even a single activity in the nuclear medicine. As the patient comes in, the quality care starts. So the most important aspect of quality assurance in nuclear medicine is patient safety. So all quality assurance processes are patient-centric. Then comes radiation safety, which is very important because we are dealing with the unsealed sources. Now, radiation safety, we have to deal with the patients. Then we have to take care of the radiation safety of the nuclear medicine professionals who are working in the department. Then we have to see the premises of the department. There should be a radiation safety protocol followed there, and the public, of course. The visitors, the relatives of the patients who are accompanying the patient, their radiation safety is also important, which comes under the quality control. Then human resource, who are working in the nuclear medicine department. Clinical service, clinical pathways, all scans protocols, whether it's a treatment or therapy, all come under quality assurance program. Then managerial activity. medical physics that deals with the quality assurance and quality control of the instruments. There are two types of instruments in nuclear medicine department. One is for the imaging, like gamma camera, PET-CT, and others are non-imaging, like dose calibrator. So whatever you are injecting into the patient, it's the right dose, whether the dose calibrated is calibrated or not, whether it is rightly measuring the dose which we are going to inject in a pediatric age group of patient, so that that instrument should be properly calibrated. That also comes under the quality assurance program. Then radiopharmaceutical. Whatever radiopharmaceutical or radionuclide is coming into the department, getting stored in the department and getting exited as a waste, as Dr. Sarika has said, every movement of the radionuclide is coming under the quality assurance program. Then radioactive material as in and out is also quality control. Broadly, the Inter-Societal Accreditation Commission has divided the quality assurance in nuclear medicine into three parts. One is managerial quality, second is technical quality, and third is clinical quality. We will deal with all these aspects in next course of the presentation. In managerial quality, for example, patient wait time, patient satisfaction, completeness of patient demographic data, report turnaround time. In technical quality comes the image quality of the scan, the region of interest placement, because that quantify the function of the organ. So if we don't make a proper region of interest around organ of interest, we are likely to have a wrong measurement. So region of interest placement is very important quality control parameter as far as the technical quality is concerned. Then the adequacy of the patient preparation. If the patient is not properly prepared before, then you are likely to get a wrong scan. So adequacy of patient preparation is very important. And then, as I said, quality control of gamma cameras and radiopharmaceuticals, which we are injecting into the patient, should also undergo radio quality assurance. Then clinical quality, the physician's performance, nuclear medicine physician's report, whether it contains all essential elements or not, or whether it has been peer reviewed or not. So all these are basically some broad description of quality control in nuclear medicine. As for the International Atomic Energy Agency quality manual is concerned, that they call it a quantum. It is a quality assurance program devised by International Atomic Energy Agency, which has 171 elements in nuclear medicine, which we have to audit to say what is our quality improvement, what are the quality parameters as per the IAA concern. As for the NABH, that is a medical imaging system. There are 214 objective elements that have to be evaluated to assess the quality program in the department of the nuclear medicine. Now, as far as the human resource is concerned, very important part in nuclear medicine department for quality assurance, there should be a qualified and trained manpower which is approved by Atomic Energy Regulatory Board. Even in NABH, it is written that there should be a trained and qualified manpower. What is that trained and qualified manpower? Because if they are working in the department, there will be assurance of radiation safety and proper image quality if the technically and qualified people are working in the department. Now, for a nuclear medicine professional one, which is a new definition now, that is a nuclear medicine physician. For that, MBBS with diploma in radiation medicine or diploma at a national board in nuclear medicine or MD in nuclear medicine is considered adequate for nuclear medicine professional one. For nuclear medicine professional two, the qualification should be either bachelor's, master's, or PG diploma in nuclear medicine technology, and that program should be approved by Atomic Energy Regulatory Board. Then comes the radiation safety officer certification examination. Either of these two, nuclear medicine physician or a technologist or medical physicist, should qualify a radiation safety certification examination, which is done by RPAD, Bhabha Atomic Research Center. So these are the essential qualification to work in a nuclear medicine department approved by Atomic Energy Regulatory Board. Then comes induction and periodic training of staff by the human resource department, like basic life support, advanced cardiac life support, fire safety, infection control, and etc. if you see this cartoon, in this cartoon, we have shown as the patient enters in the department, the quality pathway starts, quality process starts. Then patient comes to the reception desk or registration desk. After registration, patient goes to the clinic for screening of the patient and doing the history of the patient, that is the clinic. There also there is a quality assurance program. Then patient comes for the injection of radiopharmaceutical. Then patient goes to the scan room for scanning. There also quality assurance program is going. Then reporting is going by the nuclear medicine physician. And then when the patient is exiting also, at that moment, also a nuclear medicine quality program is undertaken. Now, let's start with the reception. The reception should reflect the scope of services in a very broad and very notice board manner. The scope of services include what you provide the services, and it should also very nicely describe what you don't do or what you cannot do, that we say that not available and cannot do. And there should be a list what we cannot do, like a simple example. People write refer for VQ scan. It is a lung perfusion scan or ventilation perfusion scan. But in majority of departments in India, there is no facility existing for a ventilation or aerosol study. So practically, we are not doing ventilation scan, we are only doing perfusion scan. So we should say to the patient, we should explain to the patient that this ventilation facility does not exist with us. Like many other investigations, like scintimammography. If you don't have a mammography pad, you cannot do a scintimammography procedure, then you should say that this facility do not exist with us. Then comes, if that facility does not exist with a nuclear medicine department, is there a document policy that you will coordinate that facility with some other department which is existing? Or you will say this facility does not exist with us, please, you can have this referral slip to some other hospital for inquiry. In case of instrumental failure, when you have injected isotope into the patient and you are taking patient on the gamma camera or PET CT and your instrument fails technically and you cannot do the scan, then there should be a document policy what you will do with the patient who have already been injected radioactivity. So there should be a memorandum of understanding, either with a neighboring hospital where your patient can be shifted, or there should be a policy where you can clearly say, sorry, today we cannot perform because of technical failure. Tomorrow we'll do a redo scan, and you explain to the patient what is the reason behind this instrument failure. So that is a document policy which you want to adopt, whether you want to take your patient to some other hospital, and there should be MOU signed with that particular hospital of providing that service in wake of failure of the technical service. Now, as I said, the quality starts with the reception. The patient safety and risk assessment starts at the front desk. By front desk only, you can recognize who is your vulnerable patient, whether children, diabetic patient, a very old patient. From the reception only, you can recognize these patients need a special care. So from the reception only, you know that this patient is pregnant or lactating mother. So there should be a clear-cut board here. There should be a fire safety procedure. So quality starts with the patient safety. And here, inadvertently, there should be no radioactive material injected into the pregnant patient. So there should be a very elaborated poster should be placed there that if you are pregnant, please inform nuclear medicine staff. So radiation safety starts from the reception. Then front desk has few important things to perform. There should be a policy of registration. In policy of registration, you should see what the reception should create a unique patient ID. And we should have a policy that what will be the important essential component in unique patient ID, UHID. And this unique patient ID should not be changed even if the patient is coming next time. So this patient ID should remain same even the patient is visiting multiple of times. And on the reception only, there should be a segregation of patients. There should be a facility where the pre-injected patients are sitting in a different area, and patients who have been injecting radioisotopes have been are made to sit in some other area. And there should be a prioritization, which patient will need a priority in the waiting area. like urgent, and the old people or diabetic patients will have special prioritization. So this is the job of the reception, and that reception gives a quality service in form of prioritization. Number two, whether there are available procedures and preparation information leaflets in bilingual form, either English and the regional language, which is the most commonly used language in that part of the country. And there should be a proper display of the cost of all the services. Whatever scans you are doing, there should be a proper display of the cost or information about the cost before starting the scan. This is the information booklet of the myocardial perfusion scan. Each department should have a procedure and information leaflet of all the procedures in two languages at least, English and commonly used, as I said. If I'm Maharashtra, there should be Marathi. If this is Punjab, then there should be a Punjabi script leaflets. Now, quality care in front desk is also provide, do the front desk can meet the clinical department, clinical need of the department. Is there a long waiting list, or the patients are waiting for long? This is not quality care. So there should be a proactive role where there should be a quality improvement program where we should try that there is a reduction in the waiting list of the department. There should be some flexibility or efficiency in adjusting walk-in patients or urgent request of the day. So if your department is totally full, totally scheduled, all patients are full a day, and you cannot accommodate an urgent patient, urgent scan, then it is not efficiency. So the quality improvement program should see to it that there should be a flexibility in your appointment schedule. There, walk-in and urgent request can be adjusted. So this is very important. Quality improvement program comes under the front desk. It is a managerial quality assurance program. Now, very important that you have around 20 patients on the list today, and tomorrow when you're starting the day, there are 3-4 patients, they drop out. They don't come to your schedule appointment time. So it is a no-show. And in nuclear medicine department, you cannot afford to have a no-show, both for the economical reason as well as the wastage of radioactivity. So radioactivity cost, and if it is wasted, it is a national wastage. So we should make a quality improvement program in a way, if the patients are dropped, we should have a short acting list where we can immediately adjust patient, walk-in patient or emergency patient, so that radioactivity is not wasted. So how to reduce a no-show rate? It is a managerial quality program which we have to undertake in the department. And how many patients are inadequately prepared? If we don't give proper patient instruction, people will come after taking tea and after taking food, and their scans are just cancelled or postponed just because they have taken the food. So this comes under the quality improvement program, that proper patient instructions are given. So every day we should see how many patients are refused for the scan just for inadequately prepared preparation. So this is also a quality control or quality assurance measurement where we can reduce as much as inadequately prepared patients. All your patients should be prepared properly, adequately for that particular scan. So your staff, the front desk staff, your team, which is sitting on the front desk, who is giving appointment, should be properly trained, and they should know what is each patient's instruction for a particular scan, and they should nicely explain so that patient comply with those instructions and come well prepared. Then comes pre-imaging evaluation. When the patient comes, now patient comes to clinic after registration and making clinical paper, he comes for a clinical history in the nuclear medicine clinic. First thing, a nuclear medicine physician should see an appropriateness of a referral order. If that particular scan has a clear indication or not. If it is not clearly indicated, it's not properly, the indication is not appropriate, we should talk to the doctor. Sir, this scan is, this indication is not for this scan, and we like to do this scan, which is alternative, and this will give that information which is required by you. So we should screen for appropriateness of the indication of a scan. This is one of the important performance indicator of the quality care of the department. And this should be documented. We should have a documented book where we should write this patient came for the PET CT in a known case of hepatocellular carcinoma, and this scan has been changed to another scan, and the referring physician agreed to this. So this should be documented in the book that this scan has been the indication was inappropriate, and therefore that scan has been changed. And even if there is a frequently same inappropriate indication is coming, we should have a high tea meeting with the referring department or the clinical department to sit with them and tell them, sir, we are finding after doing the data analysis that this indication, this scan is being asked for an indication which is inappropriate, and we should see to it that this scan should be done, and this is the most appropriate indication for that scan. So this is very important, and now everywhere the appropriateness of the referring indication is asked for and looked for before starting a scan. Now, second comes by the nuclear medicine physician quality assessment is the risk assessment. We are taking the history. There are certain things we should assess the risk of the patient. Whether the patient is pregnant, then we should see whether the scan is really indicate or benefit the patient, then only you inject radioactivity, or there is a contraindication. We should not do a nuclear scan, and we should suggest an alternative scan if you find a lactating mother or a pregnant mother. Or patient is old, is having an imbalance while walking, and we should understand this patient have a tendency to fall. So this patient needs an special care, quality care if the patient is old and tendency to fall. So we have to identify the vulnerable patient at the time of our clinical counseling in the clinic. Then we have to see other risk factors. We should have a checklist whether the patient have a history of allergy to IV contrast. So we cannot give an IV contrast when the patient says that, yes, I have an IV contrast allergy last time. Patient, if it is on diabetic, on metformin, then we cannot give, either we have to stop metformin. So all this risk assessment is the part of the quality care. Whether the patient has elevated serum creatinine, renal dysfunction, we have to identify that patient, and we cannot give contrast in those particular patients. In patient with 80 years of the age, myeloma, cardiac failures, the raised troponin patient, when there is acute coronary syndrome, we have to identify that these patients are contraindication for the stress scan. So these patients should be identified well in clinical screening, that so that we cannot give inadvertently stress in those patients. So contraindication identification, risk assessment is very important part of the quality care in nuclear medicine clinic. Then comes the setting of the protocol. It is the job of the nuclear medicine physician to set up the protocol. What protocol will be adopted on the scanner? The protocol can be disease specific, protocol can be patient specific or patient age specific. So that protocol is created on the prescription by a nuclear medicine physician. There should be special area where we prescribe. This is the protocol. There is a 3-phase CT scan with a PET CT and a delayed scan after 1 hour of the liver. Everything has to be described in that particular disease setting or patient setting. Then comes the prescription of radiopharmaceutical. The patient had come for a particular scan. We have to prescribe a radiopharmaceutical. Patient comes for the DTPS scan. Then we have to write a technetium DTPS radiopharmaceutical. What should be the dose? If it is a pediatric patient, we have to consider the European Association pediatric formula to calculate the pediatric dose. So it is very important job of a nuclear medicine physician to prescribe a radiopharmaceutical in accordance with the age of the patient. Then informed consent. We have seen many times the informed consents are taken very lightly. The informed consent is a very important component before starting a nuclear medicine procedure. So informed consent has these 5 Ds as an important and essential components. The right of self-determination. Patient should have a right to self-determination. We should disclose all benefits and risk. There should be a decision-making capacity. Patient should have a decision-making capacity. He should have a competence to decide about this procedure and should understand that he's understanding what procedure is going on, and discriminatory or voluntary he can refuse. So all 5D should be the part of the informed consent. Then we have a list of informed consent. We have at least 40 to 50 scans. All scans do not need an informed consent. You need a general consent of radionuclide administration, radiopharmaceutical administration. For informed consent, in all patients when we are giving radionuclide therapy, there should be informed consent. The stress myocardial perfusion scan, PET CT, including the consent of IV contrast, the cerebral and lesion shunt studies, we should have informed consent. And wherever we are giving anesthesia or sedation, while acquiring the scan, we should take an informed consent. Mere patient signature on informed consent does not mean legally and ethically a valid consent. This is very important consideration while taking informed consent. Now comes the radiopharmaceutical. You cannot do a scan in nuclear medicine without injecting a radiopharmaceutical. It is a radioisotope. When we take radionuclide with a pharmaceutical, it becomes a radiopharmaceutical. So quality control of radiopharmaceutical before injection is very important. What you are injecting, we should know that this will go only to the kidneys. It is meant for the kidney scan. So a QC is done before injecting into the patient, and a logbook is maintained that this QC is okay and this radiopharmaceutical can be injected. Is there a mechanism to verify patient ID? If you are injecting a patient, whether that radiopharmaceutical is meant for that patient or not, because these drugs, these radiopharmaceuticals do not have a label. They all are water. So we should know whether we are injecting DTP or MDP. They look same. So if a patient comes for a renal scan and we have injected an MDP, which is meant for the bone scan, so it's a wrong radiopharmaceutical has been injected. So we should identify patient ID first. We should ensure this is the same patient by at least 2 elements and then inject the patient. And we should also have a traceability of the isotope, when it was prepared, what is the dose, for which patient it is meant, and now after identifying the patient, we should inject. This all comes under the quality assurance program. Then comes if the isotope has to move in the hospital in other department, like in epilepsy, we have to inject a technician ECD for the brain, and this technician goes to the neurology department in video EEG room. When the patient develops fits, at that moment we inject isotope. So there should be a document policy in the concern in wake of radiation safety, how the patient radiopharmaceutical will move from the nuclear medicine department to the video EEG room or for the sentinel node study in the operation theater. So there should be a document policy how the radiopharmaceutical will be moving from department to other department. Then whenever we are measuring a radiopharmaceutical dose, we should know our dose calibrator, that dose calibrator is also calibrated or not. So this is very important that our dose calibrator has a quality check daily, periodically, and annually, as has been described with the Atomic Energy Regulatory Board. And there should be audit of the refrigerator, because all these cold kits are stored in a refrigerator. So we should also ensure that refrigerator, which is showing a temperature of 8 degrees centigrade, is really having an 8 degrees temperature or not. So even the quality control or temperature of the refrigerator is important. Now in nuclear medicine, if you are planning a nuclear medicine quality assurance program, each department should have a planning or a problem, identify a problem. 4 components of the PDSA cycle as suggests the plan a problem, identify a problem which you want to improve in your department, then do a data collection of that problem. The data collection will tell you, it should be a measurable data, so that you know that was a 10, now it became a 15 or it became a 20. So there should be a measurable data, because if you cannot measure a performance indicator, you cannot say whether it has improved or not. So do a data collection. Third is study. See what solution you can apply in that problem so that that problem is solved. That third component is study, and fourth is the action of that solution. So this is called a PDCA cycle in nuclear medicine department. So these are few questions or few problems. You can plan theoretically what you want to have and then start doing data collection. How you will do a data collection? As I said, it should be simple data, not big statistical analysis, because if the data is simple, then only you can measure it, then only you can do it. So thumb rule says that 30 to 50 patients per year as a sample collection is sufficient to give you a sample representation, patient representation in that particular problem. So what should be the sample size? It should represent a study population. It should find an important error trend it ensure any difference found is truly significant or by random that difference has been found. In nuclear medicine department, we divide nuclear medicine facility into 3 areas, like high risk areas, high volume areas, and high cost areas. The high risk areas are where there is a risk to the life, like a stress myocardial perfusion. The stress lab can be considered as a high risk area. The high volume area, which study in your department is high volume, like a routine nuclear medicine department nowadays, PET CT is considered to be around 80% of the load. So that is a high volume area. The high cost area like radionuclide therapy, they are very costly. So that area comes the high cost area. So if you have to do a 100% sample selection if you want to have a zero tolerance. So a high risk area, you don't want to tolerate any event. So that area should be, that patient sampling should be 100%. And the high cost area like radionuclide therapy, there also, if you're doing very less radionuclide therapy, there should be 100% sampling. Now, this is the photograph of a stress lab. In stress lab, you have so many components. You have a crash card, you have a monitor, cardiac monitor, you have a code blue call, you have a battery of the defibrillator, you have a suction machine, you have an oxygen, this is a stress ergometer, and this is a treadmill. So any machine can malfunction. So there should be a mock drill of the stress lab, so that you should see the response time of your team. If the response time, because these the cardiac events are so rare, but if cardiac events happen, that can lead to the mortality of the patient. So we should see, because of the lack of response of the team, there should be no patient should die in a high risk area. So there should be a mock drill periodically. Ask for a mock drill and see how is the response time. See for the drugs whether expired or they have still all checklists should be there in the drugs. Whether the battery is fully charged, the oxygens are working or not, whether the suction machine is working or not. So there should be a mock drill of everything. So these are the important high risk areas, and we should do mock drill at least twice in a year in high risk areas. Now, sample size in high volume area, I said if you want to have a 10% error tolerance acceptable, then you should do at least 39 cases per year. And if you can have a tolerance level of 5%, then you can see 55 cases a year for the data collection. So what is quality audit? It compares what we are doing to what should have been done as per the clinical practice in relation to national and international standards in given clinical situation. So each department should have a standard operating procedures. We should have a SOPs for each procedure, each scan, and we should not have any deviation routinely from that standard operating procedure, which is prepared in accordance with the national guidelines or international guidelines. But if there is a deviation in relation to some particular disease or some particular patient, that deviation should be maintained in a logbook. Why we have not taken a delayed picture? Why not taken the head view? Because the patient was moving. We could not arrange for anesthesia. Any deviation which has been created should be mentioned in the logbook. This is very important quality indicator. Then comes patient safety. We should have a radiation safety manual. Each nuclear medicine department should have a radiation safety manual, how you will do a radiation safety or patient. The patient supervision and isolation ward, because nuclear medicine therapy wards are isolated. It is a barrier nursing where the nursing career is done from the distance. So you can only enter in case of the emergency. So it is a barrier nursing. So how you will monitor your patients? There should be supervision of your patient by CCTV all the 24/7, because nurse cannot sit inside the room, and nursing stations are there where the CCTV cameras are there and you can watch the patient's well-being. Patients should be supervised during the gantry, in the gantry while undergoing the scan. So you can see how this is a PET CT is undergoing. These are the uptake room. These uptake rooms are isolated rooms. Patients are sitting for 1 hour, and there could be some patients which are not which are critical. So every time for 1 hour, that patient should be under your supervision while the patient is sitting in the uptake area. This is isolated area. Patient should not be neglected. So it comes under the patient safety. So we should have a continuous CCTV observation while the patient is sitting in uptake room, undergoing a scan that time also. And even the patient goes to the toilet before going for the scan. So in the toilet, patient should not fall. We will not come to know because these are all radioactive toilet. Nobody is entering for the help. So there should be grab bars, there should be emergency bell so that patient can call for the help, or there should be somebody supervising outside the radioactive toilet so that immediately the help reaches to the patient which is critical in the toilet. So these are very important. Now comes fire safety. There should be mock drill at least once in a year of a nuclear medicine department staff. They should know where is the exit at the time of fire safety, where is the assembly area, where is the route for exit for the fire safety. So these are important mock drills, and these mock drills should be video recorded, and the document should be they should be documented that mock drill has been given and who have been staff members have been attended. Where is the fire extinguisher? They should be all aware of, and how they will evacuate the patient in the time of the fire. So this training should be given by HR department, the fire safety officers, and that documentation should be maintained. Then come clinical performance, the nuclear medicine physician performance. There are many things comes which is the reporting of the nuclear medicine. Like there should be a complete report which has all elements which are essential elements in the report, from clinical indication to technical part of the study to the important finding, critical findings, some unusual finding, all, and then there should be some important scan can be advised in suggestion or biopsy or anything. So report should have all essential component. It should not be just like a vague report and there is nothing advised after that. Standard format of reporting should be followed, whether the clinical question has been answered or not. So clinical indication should be answered in that report. Any critical finding which needs urgent attention should be informed to the referring physician within 20 minutes. So that has to be there. There should be a log book maintained where the critical findings have been written, which doctor has been informed, within what time has been informed, what was the indication, whether it is a pulmonary embolism or a brain metastasis, everything should be described in that log book. Then comes the timeliness, the turnaround time of the reporting. There should be a policy of the department. What will be the turnaround time of a routine report, urgent report, or reports from the ICU or indoor. So that is up to us, that we should have a clear-cut document policy of turnaround time. Now comes the other English, as I tell, the turnaround time. Then second comes error in the report. Error the report can be caught even before dispatch. Error in the report sometimes is noticed by others when the report is already dispatched. So we should make all this as a part of incident reporting. We should know about these errors, and there should be a book where we should write, yes, there was a report dispatched wrongly, age was wrong, or there was a left or right problem, that a log book should be maintained about the errors. This is near misses, we should know about it. If we have done something, report which clinician says that this is a different report, now I feel this is a mass which looks benign, not malignant, and you want to change that report, then there should be, that report should be amended as an addendum in your packs and in a final report, and the previous report should be withdrawn. So everything comes in the quality performance indicator of the nuclear medicine physician. Now there should be a quality program in the department where the nuclear medicine report should be correlated with the histopathological findings or other imaging findings to know how many scans were false positive or false negative. That also comes in quality indication. Then comes the participation in multi-specialty meetings, like you are participating in tumor board. There should be a logbook maintained, what patients were discussed in tumor board, whether that finding was true positive or false positive. And then comes very important peer review. Peer review is very important component now for any nuclear medicine report or any imaging report. There should be the internal review process. There should be the external review process. Even in America, this has become a professional. You can see the red peer is a program where the reporting of a particular department, particular nuclear medicine physician, you can see the nuclear medicine specialty is there. So that report has been compared with an Another nuclear medicine physician which is not aware, is blinded. He sees the report and there is a interpretation criteria, whether the external peer review concur with the interpretation of the department, whether there is a discrepancy, whether this discrepancy is expected, whether it is unlikely to have any clinical significance, or it has a clinical significance. All these are the indicators where peer review is becoming important in nuclear medicine reporting or imaging reporting all over the world. And in NABH also, this is part. Then comes feedback from customers. Very important. Feedback. Who are the customers in nuclear medicine department? Your patients as well as your referring physician. So we should have a regular feedback in form of a format where the patient gives format, whether his experience was good. Yeah, just 1 second. I think 1 or 2 slides are there. So there should be a regular feedback, and there should be a mechanism where you look for the feedback and how to improve, and corrective action plan has been taken. So incident reporting, as I've said, there should be adverse event, miss, near miss, wrong scan, wrong patient, misadministration, injection of radiopharmaceutical in pregnant patient, allergic reaction or extravasation of IV contrast, patient fall, needle stick injuries, all has to be reported. There should be other incident, incorrect referral, patient ID not verified, pregnancy lactation not excluded. All this can be taken care, and if there is a good quality program is going on the department. And we should write on the boards, be fearless, report potential risk, near miss, adverse events, and encourage our staff members to describe if they have missed something, so that it is not for the punitive action, it is for the corrective action, so that it is just a culture. Quality care is a culture. Quality is not an act, it is a habit, and it should become habit of the department. There are many performance indicators of each department. You can make your own performance indicators, evaluate them on the period, see how you can improve upon them. There is a lack of time, I cannot describe all them. There may be 20, 30, anything you can make. The quality should not be part of the fabric, it should be complete fabric of your institution. Then only you can provide a quality care. And in nuclear medicine, quality starts when the patient walks in, quality ends even if patient goes out of the department. So quality control continues everywhere. Thank you so much for your patient listening.
Thank you very much.